Hey everybody, it's Alan. So in this video I'm going to tell you about the actual information that I got during my consultations about metoidioplasty with Dr. Safir at the Brownstein Crane practice in San Francisco and Dr. Chen. Okay, I'm going to attempt to do this in an organized manner. There's a lot to go through. Before I forget, I wanted to mention that something I did was in, okay, so I have, I have these packets, essentially. They're both the same, one per doctor, so what they are is 4 pages of questions that I typed up, and you know, I used to be a teacher, so this is kind of what I do. Doctor, the date, and questions with room for writing answers. So I did one for each of them. And also, since it's hard to take notes in the kind of like rushed environment of the doctor's office, I also recorded the consultations, not with video, just with audio, using the voice memo app on my iPhone. I just did it without asking. Now, I'm not going to share any of that because I did not ask. It's just for me to listen to if I want a reminder of what they said. So, yeah, I'm glad I did that. Okay, so the actual information. Alright, so again, this was mainly about metoidioplasty. I did ask Dr. Chen a couple of questions relating to phalloplasty. I didn't really get into that with Dr. Safir because, like I said in my previous video about my experience and general impressions, I wasn't feeling that great about my experience with Dr. Safir, so I didn't ask as many questions as I did with Dr. Chen. Okay, so my first question was how many metoidioplasties have the doctors done and how many phalloplasties. So both of them actually said they've done around 50 metoidioplasties, 50, and a lot more phalloplasties. Dr. Safir said that about 80% of the FTM lower surgeries he's done have been phalloplasties. And like Dr. Chen said, he's done around 50 metas and around 200 phallos. So it was interesting for me just to get that data about how phalloplasty is a lot more prevalent with trans men. So that kind of gave me food for thought, which I won't get into right now. And my next question was, to them having like done a sort of physical exam thing, to what extent did they think I would be a good candidate for metoidioplasty with everything, urethral lengthening and etc. They both said that I am a very good candidate for it, which I was glad to hear. That's due to the size that I've gotten from being on testosterone, and also that I have a good amount of sort of surrounding tissue to help him like build the parts. This reminds me, I may use the traditional medical terminology for the genital parts during this video. So if anybody doesn't like that, you can stop watching. And so Dr. Chen said specifically that he thinks that I would have a 75% chance of being able to stand to pee with urethral lengthening. And he said, well, yeah, some of this is specific to me, so I don't need to necessarily get into all that. And Dr. Chen also gave me some specific information about how the metoidioplasty would end up for me based on certain nuances of my individual anatomy. Not that I have anything like unusual, he just addressed the specifics in a way that Dr. Safer didn't get into. So that was nice about Dr. Chen. So my next question was, would the bad scarring that I had with top surgery lead to an increased risk of complications like a stricture with urethral lengthening? And well, I was going to say if you want to see my scars, you can look at all my other videos, but I guess I can show you, I don't mind, if you want a refresher. Yeah, so if you want more up-close view and commentary, you can look at my top surgery update videos from the past. So they both said that it would, like, a little bit maybe raise my risk of strictures. Now, it's not that they don't know about how this stuff works, it's just that it's hard to predict. And like the chest region is, I think, as I recall reading, it's like the most prone to keloid scarring of the whole body. And maybe like, I don't know, something like neck or ears is also very prone to it. And that's the only time I've had that bad scarring. Like, I had arthroscopic shoulder surgery, and those scars are super tiny and you can't even really see them. So it's not like I always have that scarring. But they said that it's not like I would have a huge increased risk of a stricture, and it's not like it would be guaranteed that I would have that happen. Okay. I guess I need to go through this more quickly, because I'm thinking my consultations with them were like over half an hour, so let's see if I can do that. Okay. Dr. Chen said that his patients, I guess specific to metoidioplasty, have a 25 to 30% complication rate overall in general. And there is less than 10% chance of having a fistula with metoidioplasty with Dr. Chen. And Dr. Chen also said that he has an 80% success rate in fixing strictures per attempt. So if you have a stricture, first surgery to fix the stricture, 80% chance of fixing it. If it doesn't work, if you get a second surgery to fix the stricture, there's again an 80% chance of fixing it. And speaking of strictures, Dr. Chen said that 10 to 20% of metoidioplasty patients have a stricture. And with these urinary complications, both of the doctors said that they never like abandon the urethral lengthening. It may take a number of fixes, but you're not going to abandon the urethral lengthening, I suppose, unless there's some like super freaky, super rare, crazy thing that happens. Okay, so some other sort of similar kind of general things that Dr. Safer said. So Dr. Safer, 17 to 20% chance of fistula, so that is slightly higher than with Dr. Chen. And Dr. Safer also has an 80% success rate of fixing, oh wait, no, that was about fixing a fistula. 80% success in fixing a fistula per attempt at fixing it. So Dr. Safer has a 10 to 15% rate of having strictures, which is similar to Dr. Chen. And okay, so some general things that they both said. I asked about getting a hysterectomy at the same time as the metoidioplasty, which I've addressed in a previous video about why I want to do that. they both said that it would take around the same time, like maybe around 6 hours total ballpark for the surgery. And I guess they both said that with having the hysterectomy and the meta, it's possible that I might spend one night in the hospital just because it's such an intense ordeal. And I think it sounds like for both of them, I would have to be in the area, like staying there for about 3 weeks. And speaking of that post-op stuff, Dr. Safer said that I would have the suprapubic catheter that goes in your bladder, like through your abdomen skin, which, oh God, that sounds like a complete nightmare. Dr. Safer said that I would have that for 1 to 1.5 weeks, unless there was a specific reason to have it longer. Dr. Chen said that it would be a little longer than that. Oh gosh, I don't know if I can find it, but I think he said 2 or 3 weeks or something for the suprapubic catheter. And yeah, okay. So, next, some other questions, or just about the surgery and how it goes. So they both said that they use the labia minora for the new lengthened urethra. I mean, they both were trained in this stuff under Dr. Crane, so I think they both use the same methods. And I asked, does this new part of the urethra degrade over time because it's made from tissue that is not like meant to be the urethra? And they said no, and this makes sense to me because if the tissue for the urethra is the labia minora, like there's already urine up in there like all the time, so it makes sense that it would be fine. Okay. And I also asked about the method that they use for the vaginectomy. So, because there's like cutting it out, there's cauterizing, there's laser, which I read about somewhere online. So both of them excise, like cut the skin off of the first. He went like, Dr. Safer went like this, like the first 1 or 2 inches, like the outermost part of the vag, and then they both cauterize the rest of it farther inside, which basically means burning it so that you get rid of the outermost layer of skin so it melds together. And Dr. Chen explained how he sutures the inside of it to make it stay together. He described it as like a, oh gosh, what do you call it? Like the cinching. He described it as like a hoodie sweatshirt string. He does like 3 of those in there to close it up. And maybe Dr. Safer does too, but he didn't get into that. Dr. Safer said that 40% of metoidioplasty patients get a hysterectomy at the same time as meta. And that for both of them, an OBGYN surgeon does the hysterectomy. Now, something interesting that Dr. Chen told me about the prospect of getting a hysterectomy at the same time as meta, which Dr. Safer did not get into, is that apparently with the hysterectomy, it's like partly laparoscopic, and when the OB-GYN surgeon is doing the stuff in there, like they have to sort of stitch up something like at the top of the vagina, and I don't know why they have to stitch it. I'm like, if you're taking the whole thing out, like why do you even have to stitch it? But apparently they do, and so Dr. Chen said that it can be like a little bit iffy sometimes, when he is going in there to do the vaginectomy, and he said sometimes up there where the stitches are, there can be a little bleeding, and then he has to deal with that somehow or other. Like, I don't know if stitching, but he did mention cauterizing that or something. I don't totally get it, but the gist is that Dr. Chen said that he can definitely deal with that. Like, it's okay, but it seems like he prefers not to have the hysterectomy and the meta at the same time. Or I should say he prefers not to have the hysto and the vaginectomy at the same time. It sounds like maybe it can make it a little harder for him to totally, properly close up the whole vag. Sorry if you don't like that term. Okay. So this makes me think that maybe I should look into getting a hysto some months before the meta if I do pull the trigger on this whole thing, which I have not officially done yet. So that's a whole other thing to think about. Like Dr. Chen did say that he might in the future consider like making patients get a hysto before they come in for the meta, as is the case for phalloplasty. Okay, other things. So Dr. Safer said that the testicular implant surgery can happen after 3 to 4 months. Dr. Chen said after 6 months. Dr. Chen seems a little more conservative about this stuff, which I like, because if it's going to reduce risk of complications, like, I'm all in favor of it. And for that testicular implant surgery, Dr. Chen said, like, you have to take 1 or 2 weeks off work if you have a desk job, and then 6 weeks off of more active activity. And I asked them, are the testicular implants the normal size compared to cis men, I guess? And Dr. Safer said that the implants would be an extra small or small. Saline Coloplast, that's the brand. And Dr. Chen said, yeah, they're smaller than normal. Dr. Chen also said something that Dr. Safer didn't get into, which is that with meta, the scrotum would be smaller than with phallo because just because of where things are positioned, and there's like less area to work with for the scrotum with meta. So I didn't know that before, so that was a good piece of information. So thank you, Dr. Chen. And other stuff about the testicles, Dr. Safer said that there is a 5% rate of people's testicular implants eroding out. You know, like getting infected or getting irritated or something, and like working their way out of your skin, which sounds awful. And, Dr. Chen said less than 3% chance of the implants eroding out. And I also asked, can the implants potentially erode out much later on, you know, past the first few weeks? And Dr. Chen said, yes, if you overdo it, like if you're riding a bike a lot without properly getting used to it or without properly paying attention to how it's affecting the scrotum, then yeah, even way later on, you can irritate the balls enough for the implants to get really angry and want to come out. Okay, I don't think I have too much more to cover. So I asked, have you ever had a patient who had this and this and this? First of all, have you ever had a patient who had an injury to the bowels, like when they're doing the vaginectomy? Have they ever had somebody who got their intestines nicked or something? And I was thinking specifically of the YouTuber Caden Carter, who had the very sad experience of having that happen with really bad, pretty long-term consequences. So that's like my ultimate nightmare, and I really feel for Caden so much. So both of them said that they have never had that happen. No injury to the bowels. Okay. And then I also asked, have you had a patient who's had metoidioplasty and had some like noticeable loss of sensation or problems with having an orgasm? And they both said no, because with meta, you're not dealing with the nerve, like the main nerve that goes to the phallus. Okay. Okay, so that's pretty much it for Dr. Safer, and then I'll just try to briefly mention a couple of things relating to phalloplasty that I ended up asking Dr. Chen. Let's see. He said, okay, what should I start with? Okay, so I asked him, do I even have enough material on here for the right radial forearm flap phalloplasty? And he said, I do have less than average like fat on my forearm, so I would have kind of a skinny penis if I decided to go that route. He said it would be about 3 to 3.5 inches in girth. I haven't measured that yet. I don't know what that looks like, but it's narrower than average. And he just kind of felt my thigh real quick, and he thought that if I were to go the thigh route for phalloplasty, I would have an above average thickness. Yay! So that's no, not going to happen, because the thigh phalloplasties are very girthy to begin with, so that would just not work unless I lost a bunch of weight, which does not seem to necessarily be in my future, because I've already tried. I'm like always trying to lose a couple pounds, because as I said before, I have a lot more in here than I do on my arm, but haven't been good at losing a couple pounds yet. And Dr. Chen said he does not do MLD phalloplasty, which is where they use some of the skin and also a little muscle from the latissimus dorsi, because he said that that spot only has a motor nerve that goes into the muscle or something. It doesn't have quite so much of a sensory nerve to the skin in the same way that the forearm does or something, so he does not do MLD. Okay, I think that's probably it. At least in terms of the stuff that might be relevant to you guys. So I'll bring it to a close. I hope that you found that useful, because that's my goal here. Let me know if you have questions, and thank you for watching. Bye.